Hello, my name is Alison Wickham and I'm an advanced clinical practitioner in a Birmingham trust. My colleague and I developed an outpatient large volume paracentesis clinic for cirrhotic patients where drains were placed without ultrasound guidance. For those patients requiring ultrasound guided drain insertion, the local radiology departments would not place drains if INRs were greater than 1.5. Discussions were held with individual radiologists who would be happy to complete the procedure despite INR results. However, reluctance would come from the departmental staff and procedures cancelled at the last minute due to extended INRs. This would lead to an extended hospital stay due to having to correct the coagulopathy in accordance with the local guidelines. There have been papers published that have indicated that the correcting of abnormal clotting is unnecessary, as there is a low risk of bleeding complications in those patients who require large volume paracentesis. Within the ACP clinic setting, we did not routinely check INR or platelets prior to drain insertion. Instead, we used the last set of bloods taken as a guide as to whether drain insertion was appropriate. A retrospective audit of all the procedures completed within the ACP clinic over a 3.5-year period was undertaken to assess for any type of complications following paracentesis. We were predominantly looking for any bleeding complications post-procedure. A total of 219 procedures were documented from the 2 ACP's data, and the majority of these patients having alcohol-related liver disease. Platelet and INR results were collected and UCAL scores calculated. Only one patient was on warfarin with a target INR of 3.5 and required bridging with low molecular weight heparin. INR was corrected to 1.5 prior to drainage. All other extended INRs were not corrected. One patient had platelets of 34 and required correcting prior to drainage. There were no bleeding complications from any of the procedures completed. There were 2 procedure complications. One was cellulitis of the drain site, which required treatment with oral antibiotics, and the second for excess acidic leakage post-drain removal. This did require hospital admission for fluid management. The audit shows that coagulopathy does not preclude the insertion for paracentesis drains, and therefore drains can be inserted following clinical examination, either at the bedside or with ultrasound guidance within the radiology department. Thank you.